My lecture is not about, propagating myself or teaching you new things. My lecture is about vanishing breed of sexual medicine doctors, the GPs in India. So this has always intrigued me as what can be done for GPs in India, because India, GP is not the first point of contact, and consequently, GP is bypassed in many of the instances, be it a pediatric problem, be it a respiratory problem, be it a cardiac problem. GP is the last cog in the wheel, and consequently, we have to accept the fact that the remuneration potential of GP is coming down drastically. And consequently, my thought process was a couple of years ago when we started doing this, how do we empower the GPs? What we can do to empower him to stay relevant in an Indian scenario? And that's the whole concept all about. So what I'm going to talk about is what you can do in your practice, not what I want to do in my practice. So this is about talking about precision diagnostics in a GP clinic, and that's what it is. We have developed several algorithms. Somebody was talking about just now AI. To tell you honestly, AI is all-encompassing. It is going to something which is going to emerge. Recently, we did an AI tool where people talk about semen analysis, where just to give you an example, you need to bring the sample with 45 minutes to the lab. I can give you a buffer. You can collect it wherever you want in 24 hours. I can tell you exactly the same semen analysis report. So that is because we have the database of patients who have undergone. So the time deterioration of the semen sample has been calculated, and consequently AI can predict what was the original sample at that point in time when you collect it. So that is the power of AI. So I'm not going to go into that, just to mention briefly about that. So what happened in specifically in regards to sexual function is we used all irrelevant tools. None of them gave us precision diagnostic capability. We started with the era of psychosexual history, then we went to NPTs, then we went to injection, and then we said biomarkers of neuroimaging. You can name more things if you want. None of them have stood the test of time, and consequently we are still struggling with patient-directed questionnaires, and consequently there is a lot of bias in each of us in the way we elicit these answers. So all these are put down. You have neurophysiologic testing, audiovisual, vascular testing. None of them have stood the test of time. So what am I trying to get into? What has been adopted in clinical practice and done for many years is your IEF, SEP questionnaire, global efficacy question, your pairs. You can name all our questionnaires-based assessment. At the end of the day, there's a huge margin of error in the questionnaire. If you give it to 3 people to ask the same questionnaire, there will be a margin of error. So consequently, and your investigation tools are your HbA1c, your chemistry, or your lipid panel, and consequently NPTR is an outdated test, does not give any clinically relevant data. I'm sure most of you will disagree with me, but that is my opinion. I think NPTR is clinically irrelevant. Still some courts ask for it and we do it, but at the end of the day it doesn't give you clinically meaningful data. So where are we? Why are we talking about this? Basically because predominantly India being the metabolic capital of the world, where we have dyslipidemia, where we have diabetes, where we have hypertension, we have abdominal obesity, which contributes almost to 60-65% of the population, we are looking at vascular health. Some time ago, there was a paper by Francesco Montorsi. This was way back in the early 2000s or the late 1900s, where he talked about heart attack risk and sexual dysfunction. And that is where a lot of people started looking at what is this heart attack risk and MI. So we are looking at, what is it that we are looking at? We are looking at vascular risk. Is there a vascular risk, which is the preponderant risk in population? You hear a lot of athletes who are in their 40s gymming regularly, dropping down dead. And similarly, you see marathon runners having recently go ahead and a couple of months ago, a marathon runner who died. So consequently, we are looking at whether we can predict ED through a vascular risk. Whether vascular risk can be predicted through ED, because ED, as you know, even a Google study is looking at retinal artery, and the retinal artery size and the penile cavernosal artery size is almost similar. So consequently, people are looking at predicting. Google has a major study on the retinal artery to predict MI through Shankara Foundation. So consequently, ED versus CAD, pathophysiology, came up, and we are looking at endothelial dysfunction. This is what we are talking about, because we know that endothelial dysfunction is all-encompassing, especially in the South Asian population. It may be related to diet, it may be related to your genetics, it may be related to whatever you want, hereditary aspect, but we are looking at endothelial dysfunction to first understand, and consequent to that, if there is an endothelial dysfunction, you have a natural history which will happen, which is your endothelial dysfunction will lead to elevated blood pressure, then you have arterial wall thickening, then you have plaque formation, and then you have clinical events. So consequently, this is something which will happen in majority of the individuals. So can we predict this early? So we are moving away a little bit from sexual dysfunction, which is what the patient presented to us with, but to look at it in a more holistic and a preventive way of assessing endothelial dysfunction. I will link all this as to what the GP can do a little later. So what is it that we are talking about? You have a normal endothelium where you have a normal tunica, you have a normal adventitia and a media and a normal endothelial cells, which is necessary for your nitric oxide signaling, which is absolutely necessary. Then you have a dysfunctional endothelium where the bioavailability of endothelium-derived nitric oxide generating decreases, and this results in a decreased vasodilator response and also becomes pro-thrombotic and pro-inflammatory endothelium. That's what happens. Then you have an abnormal endothelium which plays a pivotal role in atherosclerosis, and this is probably represented by slightly higher LDL level, which also happens in these individuals. So that the endothelium undergoes a multitude of changes in some individuals, and this is what presents as erectile dysfunction in many of the instances. So consequently, what does endothelial dysfunction eventually do? One is at the lining level, where it affects the nitric oxide synthase capacity, and the second is arterial stiffness, where the arteries contain smooth muscle, elastin, collagen fibers, and the elasticity and flexibility over the time deteriorates, resulting in structural integrity problems, loss of elasticity and flexibility. This is what happens to the coronary artery, and that's why we get stented if at all we have a problem with the coronary artery. And this leads to progressive capillary damage of the penile vasculature, and this is what leads to ED. So could ED be an indirect marker of an early heart attack risk? So consequently, people have looked at various ways of measuring this. How do we measure the vascular impact? Is there a vascular impact in this individual at the level of the terminal arteriole? That's what we are looking at. Cavernosal artery is almost like a terminal arteriole, which is very small, and this is the way people looked at various measurements and tried to see whether we can measure the impact of ED on the vascular system, overall vascular system. So this is where I want to bring in sexual dysfunction evaluation beyond your scores. Let's move away from all our scoring patterns, our psychological assessment, and IAF, SHIM score, EDIT score, global efficacy question. All of them are symptom related. If you ask the same patient 3 times in 3 consecutive days, he will give you a different answer. So consequently, we are looking at endothelial testing. Why do we need this? Because we have diabetic population, hypertensive population, dyslipidemias, post-smoking population. All these are vasculopathy inducing causes. And this is definite. And we have a huge population of ours has metabolic syndrome, which leads to inflammation, impaired regenerative capacity, and endothelial dysfunction. All contribute to arterial stiffness. So that is what we are dealing with. So how do we measure this? This is similar to patients with coronary artery. There is always a synonymous idea or that arterial stiffness eventually leads to penile arterial stiffness, and this is global phenomena. All vessels get affected, so these patients also have coronary artery disease. So if we can detect abnormal endothelium or abnormal at the peripheral level, probably we are able to detect one patient at the coronary level. I can give you multiple histories where we have been very successful in this and prevented a lot of people from developing heart attacks. So these are the various tools which we have used for measuring this peripheral arterial stiffness or your endothelial dysfunction. People looked at numerous metabolic factors, if you're high LDL, low LDL, diabetes, smoking, but they are crude factors. But what was people looking at is carotid IMT, plaque measurement by ultrasound, and coronary calcium score, ankle. But we wanted something simple, which is doable at the GP clinic. That is what you require. You don't want a complex instrument which will measure. So when you look at sensitivity and specificity of these equipment, I've put down a various list of equipment. What we are looking at is pulse wave velocity augmentation and peripheral arterial tone. You can see which reflects biology and reproducible, repeatable, non-invasive, and this is what is required at the peripheral level, and that's what I'm coming to. There are equipments which can measure at the GP clinic, something which you can develop where you can measure the arteriolar health, because this is what you want to know. At the end of the day, I always believe that every patient has a psychogenic problem. Even I have a psychogenic problem. If you make me sit in front of Rao, he will tell me I'm either depressed or I have something else at the end of the day. So consequently, it is something we all go through, because we have cycles of, nobody is perfect in this world. And consequently, what we want to understand is, fine, you have a psychogenic element, you have always lived with it, but is it significant enough in you, or is there is something else which is more predominant in you, consequent to which you have developed the psychogenic event? So that is what we are trying to develop. Agreed, Rob? So anyway, he's the master in psychology or psychiatry, and I'm not going to contest with him. So we are looking at a tool to measure terminal arteriolar health, because that is what you want to know. Because ED is all about terminal arteriolar health disarrangement, and that is what we want to do. So people measured brachial reactivity, where you create a suprasystolic pressure of the brachial artery, release the arterial pressure, and then measure the peripheral, vasodilatation at the finger level. Again, had some amount of complexity, because it depends on the room temperature, it depends on whether the patient is, the periphery is cold earlier, so you have to set the room temperature ideal, you have to pre-warm the patient, so a lot of restrictions were there in that kind of a environment. So, but essentially what the test proved was, if you create a compression and release, there is going to be a vasodilatation. And how much of this vasodilatation is what we people determined, and said if the vasodilatory capacity is not normal, or you can put a range to the dilatory capacity, and that indirectly tells you the level of stiffness of the artery is what you have. And that is what you people have tried to look at. And then people looked at pulse wave velocity. What is a pulse wave velocity? You measure the carotid to femoral transmission time, because this is a medium-sized artery, and you want to measure the carotid to femoral transmission time. There are specific transmission time indices which are available. So whether it is slower than that, faster than that, it will tell you the health of the artery, because blood flows through waves and stresses phenomena. So consequently, the pulsatility of the blood vessel will determine the flow from point A to point B. So that is what it is all about. So the emergence of pulse wave velocity made a lot of difference, because we now know that pulse wave velocity can get affected in arterial stiffness, in systolic blood pressure problems, diastolic blood pressure, heart rate, augmentation index. So in all this, pulse wave velocity is the first thing which gets affected. And consequently, what is pulse wave velocity? Essentially, it is the speed of the wave which is related to the stiffness of the artery it is traveling in. The speed of the wave, it is like you have a supple tube delivering water from point A to point B. If the tube is supple, the water will flow faster. If the tube is stiffer, the water will flow slower. So consequently, that is the concept of the wave speed is proportional to the square root of arterial stiffness, and that is what is pulse wave velocity all about. So this is what is the equipment which was developed by Genesis Medical Systems in Hyderabad, where we have put in an algorithm. And why did we put in this algorithm? Why do you need an algorithm? Because at the end of the day, I'll just stop it for a minute here. 1 second. How do I stop it? Okay. So why did we put in an algorithm? It's because I realized the machine initially was marketed for just measuring the central arterial pressure and endothelial dysfunction. And that was targeted at a particular group of people who are probably cardiologists or physicians. But now cardiologists are not interested in buying an equipment to tell them whether there is arterial stiffness or endothelial dysfunction, because they have much more advanced tools. They can do an angio, they can do a cardiac CT, and so they have much better tools to assess. So then we said, can we integrate this into sexual medicine practice? Can we use this tool to detect endothelial dysfunction in individuals? So how do we do that? So we did a study of almost 600 patients, and then we developed an algorithm. Why do we need an algorithm? It is like this. When I started, just to give you an analogy of an example, when I started doing this urodynamics some time ago, because I was trained in neurourology, all of us have this fancy habit of giving, the terminal end impression as hyperechoic, non-neurogenic, neurogenic bladder with hypercontractility, with atonicity, with detrusor-sphincteric dyssynergia. Now, this was the type of diagnosis which used to be pushed to the physician. It is like getting an ultrasound report saying that right kidney shows hypoechoic lesion, left kidney shows 3 centimeter hyperechoic lesion. Your clinician wants to know what is the clinical diagnosis. He's not bothered about your medical terminology of putting in all this jargon, which you may still use. Then I modified my urodynamic report saying that this is the terminology, but below that I said this is an obstruction, this is underactivity, this is a detrusor-sphincteric dyssynergia, this is the management strategy. That was a huge hit, and we are one of the biggest urodynamic centers where we do for all urologists the urodynamic, which I consider as a privilege because they trust the report. So similarly, we said, what does the GP require or a sexual medicine practitioner require? He doesn't require this complex equipment to tell him, peripheral arterial stiffness, oxygenation poor, central arterial pressure high, pulse wave velocity low, and all that. He requires to know, what do I do with it?
Time is over.
Therapy, yes?
Kindly see the time, sir. Time
yeah. Will medical therapy work or will medical therapy not work? And so consequently, and if it is not going to work, what do I do? So we built in an algorithm which tells you precisely what you need to do, as to what is the next steps you need to take, what are the treatment options in that given individual on the basis of the report. This is like an ECG based report, and that is what we have tried to propagate. Okay, so I'm going to just play this video. If you want me to finish, I'll finish now. No problem.
Function, reduced blood flow, stiff arteries fail to dilate properly, limiting the blood supply needed for an erection. Early cardiovascular warning, the penile arteries, 1 to 2 millimeters, are smaller than coronary arteries, 3 to 4 millimeters, so ED often appears before other cardiovascular symptoms, making it an early marker of vascular disease. Why arterial stiffness testing matters. Non-invasive testing device periscope does pulse wave velocity, PWV, and central aortic pressure, CAP, test and can detect arterial stiffness, which helps in treating ED effectively.
Sir, you can take 10 more minutes.
No problem. I'll finish. Okay. So what I'm trying to say is, so we give the report in a different format. You can see the report. I'm not going to go through this. So the report comes in different formats. Forget about the content of the report because some content is medical. The rest is all management strategy. So what you need to know at the end of the day is, I send for a CT, MRI, I get a management strategy. So similarly, I send for an ultrasound, I get a management strategy. I send for an ECG, don't ask me to interpret the waves. You tell me normal or abnormal, that is what I need to know. Similarly, this machine has been modified to give you a management strategy so that you can start monetizing or treating the patient appropriately, and that is what the whole concept of this report. So that is what we have tried to do. At the end of the day, I'm just skipping this because this is not relevant for this point in time. So we have done that, and this was the original format of the report which we have changed. And the concept is, when we did this, is that through the machine we identify who has early endothelial dysfunction and vascular stiffness, who has moderate endothelial dysfunction and vascular stiffness, and who has severe endothelial dysfunction and moderate vascular stiffness. Indirectly, it also tells you who requires an echo or a treadmill immediately, so that he is a high-risk candidate for a heart attack. So that is the prognostication which this machine can do, indirectly saving lives if you use it properly. So we have done this, and so we've developed this. So this was the Princeton algorithm panel which has been used by many years now, where people said this is the way to evaluate. Now this is my own, where we have added evaluate with new tools, because the algorithms have to change. You can't stick to the same algorithm which was developed years ago and go on talking about conferences in the same way. So we have modified this algorithm. So essentially what this lecture was all about was, there is an algorithm called ALLO algorithm. What is the ALLO algorithm? Ask, legitimize, limitations refer, open for discussion, work for comprehensive plan. This was the original ALLO algorithm, which was developed. Obviously, you have to ask because ED, many patients are not interested in opening up, legitimize the problem, limitations to refer. This is what it is. This is what I disagreed with. There is no need to refer any patient of ED. You need to manage it yourself. If you manage it yourself effectively, all patients will stay with you. Mind you, the amount of people who require surgery in an ED is less than 10%. 90% of the patients do not require surgery. And that is my strong belief, and that's what we have aimed to achieve. So consequently, if you decide ED severity by the questionnaire, there is a risk stratification by comorbidity, then you have these additional tools of evaluation, endothelial assessment, arterial, pulse wave analysis, large size artery, and then of course you can add an andropause assessment as maybe because of testosterone and other things. Then you get your management plan, and the management plan can be medication, shock wave. If it is shock wave, which shock wave, how many shock wave, when to give, what is the response rate, how many people will respond, everything we will be able to tell you. And consequently, if it is platelet-rich growth factor, what is platelet-rich growth factor? Are you going to take 10 ml of peripheral blood and inject into the penis, which will never work? So those are the questions which have been answered. And also one additional parameter which I have put in that machine is that at any point in time you don't understand, there is a personal WhatsApp number where you can ask and we will clarify whatever your doubt. Essentially, we are putting on our reputation online for a management, your management to work as much as what it works for me. And that's what it's all about. And I'm sure the company people will be able to explain to you better. This was my passion. I don't need to do this because I can have all this equipment in my clinic, but I thought this is the way to empower the GP. My next lecture is about empowering the GP to survive in this medical world where he is getting marginalized. Thank you very much. So if you permit, I'll finish my next lecture also.
Next lecture? So you have one.
Is it next immediately? I thought it was immediate. Yeah.
I'd seen the report which this machine was giving, and is giving the all treatment patterns and treatment plans also. So I made a modification. I think they should not be given to the patient itself.
No, that is an optional for you to print out.
Yes, because they were telling me this, we'll put this thing in there, because if we are giving the treatment pattern to the patient themselves, they say, sir, you're not using the line 1 treatment, you're using line 4 treatment. I think that should be modified.
No, we have already done that.
You've done
I
that,
don't know why they didn't explain to you.
Right.
See, all urodynamic options, if you look at a urodynamic machine, it tells you what you want to print out.
Perfect.
It tells you whether Euroflow you want to print out, CMG you want to print out, whether you want to print out an EMG. Similarly here, this doctor's copy, it's called doctor's copy. It is your copy.
Right.
So you can print it out and not hand it out, or you don't need to print it out.
No, we need to print out, but we should print out the only that whether it is a severe ED or not.
That is
which we should give to the patient.
No, at the end of the day, you mean to say like that. Okay,
Yeah.
that's a good suggestion.
Right,
okay.
sir.
Fair enough.
Because
Okay.
if patient is giving just these pages, he'll say, "Sab ye hai kya? Mere samajh mein kuch nahi aa raha hai." So he should be given that.
Valid,
yes,
valid
sir.
point. Okay.
Right, sir.
I agree
Thank
with
you.
Thank you. That was a good feedback. Okay, I'll do it. You got the feedback?
Sir, please go ahead.
Yeah, this is about future of sexual medicine. I call this the future of sexual medicine because I've always worked in what is the pain point of the patient. At the end of the day, we are physicians, we have to address the pain points of the patient. It is not what my textbook gives. My textbook may not have evolved to understand the pain point of the patient. What are the pain points of the patient? As far as I know, male infertility is the biggest pain point for the patient basically because he is a normal, healthy individual. Somebody tells him you require an IVF, you can't conceive naturally. He just doesn't understand that as to why it should be. Post-finasteride syndrome is a pain point for the patient because something which has gone wrong, which was normal just because he took a drug. Post-orgasmic illness syndrome is another pain point for the patient where he doesn't understand what's happening. So these are all pain points for the patient. It's very easy to brand them as psychogenic, organic, but at the end of the day, these are pain points for the patient, which are, and We all talk about penile dysmorphophobia and say that you should live with a penis which is 3.5 inch because my textbook dictated that 3.5 inch is enough for sexual penetration. I want to ask all this audience, if your son has a 3.5 inch penis and you say you are going to live with it for the rest of the life and he doesn't want to live with it, do you want to agree or you don't want to disagree? So it's all about what is today's era. Today's era is about living the life to the fullest, living the life the way you want, not what the textbook dictated. It's my life, one life, and I want to live the way I want. At the end of the day, nobody has the right to tell me that this is the way you should live. And that was history because we didn't have options then. Now is an era of where all these film stars, I see Trump at 78 having that energy and amazed at that. I want to live like that. There's nothing wrong with it. You can't advise me, you have developed Vriddhashram, so you sit in the house and just be happy with what you are because that's what your forefathers did. So we are moving into that kind of an era. So this is about what is changing in the frontier of sexual medicine. Why this presentation? Basically, I wanted to put this background because we have done andrology for the last 25 years and we have pioneered several new innovations. I don't want to go into that. But what essentially we are offering is andrology is an all-encompassing term, male fertility, ED, men's health. And so when we looked at what we want to do, at the end of the day, male infertility is an other than semen analysis, which is a jack shit of an investigation, doesn't tell you anything, is irrelevant to the male. At the end of the day, you are branding him oligo, astheno, teratospermia, which has no meaning. At the end of the day, oligo can be anywhere between 0.1 million to 14.9 million, which is oligo. Astheno can be anything between 1% to 39%. So it's a huge range which you are giving him, which doesn't make any sense. So male fertility diagnostics has moved into an era of precision diagnostics. I want precision to know what is my condition. I'm not bothered about you branding me in a global, holistic way. So we have moved into, in Rajajinagar Ankur, where we have DNA fragmentation, we have ROS, we have acrosin, we have annexin, we have izumo-1 protein. This was not the brief of the lecture, but I just put this up because male fertility diagnostics has come to the cutting edge of technology, where we can precisely tell you with one test how you will conceive. How you will conceive, with what modality you will not conceive. And that is the power of diagnostics with male fertility. And that is something I wanted to mention. I'm not going into that. If anybody is interested more in that, and all that are hub and spoke models, so you can have these tests at your center and you can develop this set. We will tell you how to transport it to our center and get you the report. So second thing is, similarly, sexual dysfunction. Nobody, at the end of the day, why did Viagra come into the market? You always had psychogenic therapy, you always had a vacuum device, you always had an intrapenile injection, you always had a vibrator. You could have used that for time immemorial. People want naturality. At the end of the day, that is the dream of everybody. Nobody wants a penis which is, having a ring at the base of the penis and you're trying to suck the penis every day morning to get an erection. So consequently, people are looking at reversal of their problem, staying as young as possible. That is a dream. If you want to stay young physically, you might as well stay young sexually. And that is the concept which people have. And secondly, preventive. If I can know my overall health status because of my vascularity in the penis, then it's an added advantage. So what are we talking about when we are looking at overall andrology products and services? Just to give you, we have grade this diagnostic andrology. There's an advanced male infertility with, one is to have all these tests, but you need to automate these reports. At the end of the day, reports, like I said, is meaningless if it doesn't tell you a management plan, and that's what we want to do. And vascular disease, endothelium, vascular stiffness assessment, as I said, men's health, mortality barometer. What I want to know is, am I at risk of developing something critical in my life, and should I do anything about it? Reproductive barometer, how long I have in terms of this one, sexual or fertility. And then reproductive growth barometer. There is this concept among pediatricians which I find it amazing, that you have to wait for the growth spurt at the age of 14 or 15, and if it doesn't come, your son or daughter will stay at 5 feet 4 or 5 feet 3, which he doesn't want to. So can we proactively treat this man? And that's what I call as reproductive growth parameter. Because why should we wait for this growth spurt, which may not happen at the end of the day? It is not a guarantee. Are you guaranteeing me that it will happen and I will grow? It may not happen, and at that point in time, you don't have options. So that is what we are looking at. So essentially, the areas of diagnostic services which probably a sexual dysfunction practitioner or a GP in India can develop is male infertility, erectile dysfunction, men's health risk assessment, and preventive wellness. These are the areas where you should be in, because these are areas where people are not interested in a corporate hospital. These are areas where people are not interested in going to a no specialist is offering these services. So you might as well capitalize this and develop these specialities. So what is it that you can offer? At the end of the day, male infertility, do you require a complex setup? No, you just require to advertise this test and we'll help you develop this. Vascular disease, I already told you there's a machine which probably costs you somewhere in the 5-6 lakh range. You can talk to them. And then you have this. So these are all risk prevention. At the end of the day, you have a patient base which you can propagate this and tell them these are the services you are offering. Each of these services will make you confident with your patients. Each of these, whether you like it or not, you require monetary compensation. Without monetary compensation, none of us can survive. At the end of the day, you need monetary compensation, but not at the cost of cheating a patient, but at the cost of benefiting the patient. And that's what you require. And that is what it is all about. So male fertility, just to give you a brief, we have all these tests: advanced semen analysis, DNA fragmentation, by flow cytometry, reactive oxygen species, atrazine post. Now we added a new test called Isimo-1 protein. So what it does, it's a hub and spoke model where we give you a buffer. You can send a semen sample from anywhere in 48 to 72 hours. We'll be able to do the test. There's no need for the test to reach me in 15 minutes. What it does is, your patient doesn't go out of your clinic, and he gets the treatment management plan directly written to you, and you become the primary doctor to convey what you want to convey. Maybe it's an IUI pregnancy which you will advise, maybe it's an IVF pregnancy, just to give you an example. So when we thought about this, is it going to work at the end of the day? Because any concept you can have, it's in the air. Vasan can talk about it, but does it? These are the basic questions we had. Is there a need for this diagnostic service? Where to establish? What are the strengths? What is the space, resources, equipment, technology, infrastructure? Where to set up the hub and use the existing hub? Competition analysis, risk analysis, market size. I'm basically an entrepreneur, so I can do all this. And so we did a SWOT analysis, just to tell you, I'm sure many of you, strength, weakness, opportunity, threat. That's what is a SWOT analysis of any organization you do. Strength, unique service, adding a physician assisting treatment plan provides a clear competitive edge. And that is what will happen to your clinic if you do that. A new service line can start using existing footfall and leverage these services. Then beneficial aspect of organization, customer goodwill, and brand loyalty will be enhanced. That is the strength of adding this. What is the opportunity? Chances to make greater profits, offer technology with a difference. Post-COVID, there's a greater awareness of preventive health, and also data suggests that reproductive sexual health are declining post-COVID, and also environmental factors like global warming and others adding to the problem. So, can use this logic to add new streams of revenue which have higher margins with minimal dependency on other doctors, because you don't want to be calling a urologist, you don't want to be calling a psychiatrist, you don't want to be calling Rao, because he will have his own fees, he will have his own charges. So you need to have something which you can do in your clinic. New opportunity arises as there's a need to address lifestyle issues in public and also empower doctors to treat better and enhance their economic realization. There is need to be, there's nothing to be wrong about talking economic realization. You can't be talking without having economic realization. If an engineer applies for a job, first thing he'll look is, what is my salary, what is my CTC? That's what he's going to ask at the end of the day. So what is the weakness? Some players exist who offer part of the services and they should scale up their offerings. Growth is also subject to convincing existing doctors and doctors outside the system to use services in B2B model. Acceptance, and this is something which you can, if you want to ask me, I will send you later. So threats are also there. There are some threats which we perceive. So essentially what it does is, so what I'm trying to say is, each GP clinic can be empowered as a sexual dysfunction diagnostic lab, which will enable you to treat your ED patients with much more confidence, much more efficacy, and much more reliability, and that's what you require. And men's health diagnostic, you can add all this mortality, you can call it whatever you want. I've just put these names, it need not be the same, but mortality prediction, fertility barometer, miscarriage barometer, sexual barometer, premature ejaculation barometer. I have thought of many names, and you can use it. And we also propose to the Karnataka government, when at some point in time, where, because this is something which I put up because heart attack is happening to younger individuals nowadays, and that is what it is. And these are some of the stories of heart attack which you can, and most of these could have been predicted by looking at the high risk vascular score in these individuals. This is what I proposed to Karnataka government, and they have taken it up, where we said, what is men's health all about? Is it after looking after the hair, which is graying anyway in my head, or is it looking at my fitness, or is it looking at my speech, is it looking at my dental, which is looking at my eyes? I said, no, we are looking at only 5 parameters which will give you longevity. One is reproductive and sexual health risk. Why? Because it may be an early product of heart attack. We are looking at cancer risk, stroke risk, heart attack risk, bone health. If you have these 5, you will live. Whether you will be, looking great like Shah Rukh Khan, or you will look ugly, that is entirely different. But the longevity is not going to be compromised, and this, we have started this as a program for all diabetic patients and hypertensive patients in the state of Karnataka, and this is what is Men's Health Risk Assessment Clinic. So I'm giving you ideas how you can propagate your clinic. And these are the various verticals: heart attack risk assessment, stroke risk assessment, bone health risk assessment, male infertility and sexual risk assessment, and cancer risk assessment. And these are pretty much standardized tools nowadays. So overall, you can have in your clinic at a GP level, you can have male infertility, which if you are confident, you can add restorative and regenerative therapies. We'll teach you how to do it. Sexual dysfunction, you can add your shockwave therapy, men's health management, and so on and so forth. And God forbid, if some patient requires surgery, you can always have a tie-up with a urologist or somebody who can do this surgery for you at that point in time. Now, when I conceived all this, I said, everybody will think that it is because I am successful and running an Ankur center in Bangalore, I should be successful everywhere and anything will work with me. So I said, no, let me think of doing it in a different way. So I created a different brand called Ankur Urja, and this exists in Goa. Why Goa? Because it's a tier 2 city, and second, it's a matriarchal society. Goa is dominant matriarchal society. People said sex will not sell in Goa. It will not happen in Goa because it's a matriarchal society. So we said we will start here, and we started here. We have been now about 18 months, I think, and we have been extremely successful. And the clinic, anybody can visit. It's in Panjim, and it will tell you how you can develop your clinic. Of course, this is in 800 square feet of space. We have a business plan to do it even in 300 square feet of place, or modify your existing clinic. So what do we offer? So these are the various areas when this thing Ankur Urja offers: men's health concern, restorative treatment, health and longevity, wellness and longevity technology, genital growth concern, women's health concern. So a lot of things we offer in Ankur Urja which are unique and nobody else offers. So additionally, we have several patented products. Whoever ties up with us, whoever wants this thing, we will be able to help them with various other technologies. We have our own nutraceuticals, we have our own sperm buffers, we have our own course which we can offer you to empower you. Tomorrow if somebody asks how you practice, so we can also empower you. I have an IMA course. I have, of course, like Ajayan said, none of this may be recognized by the council, but at least you have some sort of a degree which can help you. So we developed Spermio, which is the first product developed by a urologist to assist in IUI pregnancy. Nobody is interested in an IUI pregnancy because when you have IVF, which is a better monetary tool, why would you want to have an IUI pregnancy? So we developed a hyaluronan-based meat buffer, and we have Onova because we said azoospermia is a distressing problem. Everybody will say, get a testicular biopsy done, or a TSA done, or a micro TSA done. Can we predict presence of sperm or not? We developed that tool, and we have, to break the barrier of transportation of the semen, we said, why should we use liquid nitrogen? Can we transport it at room temperature? We developed Zapnil and all that. And then we have nutraceuticals specifically addressed to abortion risk, fertility risk, and these are food supplements. These are not drugs. And consequently, I said, why should we use drugs? At the end of the day, there are a lot of people, how is that innate immunity developed in certain individuals, and why is it not there in certain individuals? So we developed food supplements. So these are the gamut of technologies which we have, and we also have, so what I'm proposing is, look at how you want to empower your practice, how you want to upgrade your practice. The tools are available for you. Any help from my side, you're most welcome. Upgrade your practice. You will be able to stand out among the crowd. you can be the sole sexual medicine specialist in that city or area. We will help you with digital marketing strategy, we'll help you with software, we'll help you with algorithms, we'll help you with the front end of diagnostics, back end of nutraceuticals. We have the complete gamut of facilities available to empower you. So thank you very much. And we are also offering services to unmarried people where we have programs. I think Murugan brought this up some time ago. In Tamil Nadu, there was a hue and cry. I think Manorama started this, saying that there should be a sexual health test for all men. Am I right? At some point in time. And so we have used that as a tool. So just to summarize, ladies and gentlemen, this is a standing clinic which is in Panjim Pato, Gera Imperium Star. The room number, Harsh is here, he is a part of my team. Is it room number 116? 115, okay, 115. It's in first floor. Lively model, doing extremely well. It's one of the popular clinics of Goa. When we started it, people said no footfall will ever come to you. I said no problem, we will see, and we are extremely successful. Thank you very much, Ajayan, and thank you very much, IASMPMM. I thought it was my duty in this lecture to tell you, in this cluttered world, how do I stand out? And that's the purpose of this lecture. Hope I made a difference. Thank you.
Yeah.
Thank you so
Thank
much.
you, very nice presentation. Any question from them?
I think it has given a 360-degree perspective. Thank you, sir, for being here and mentoring us. And whatever number of doubts we were having, I think almost they are solved. And thank you so much, sir, again. Sir, please. I invite Dr. T.S.S. Rao, Dr. Murugan, Dr. Ajayan to felicitate Dr. Vasan, sir.
इधर कर देना, फोटो बीच में रहेगा.
इधर से सर
Sorry, sir.
Dr. Ajayan is gone around, I suppose. So, meantime, we can carry on. No, he's not there around.
Give it to me. I will see.
ನೀವು ಹೇಳಿದ್ಮೇಲೆ ನಾವು ಮಾಡ್ತಾ ಇರ್ತೀವ